All right, good afternoon, everyone. Very nice to be here this afternoon with all of you. We're going to be discussing today patient safety and quality improvement for the pediatric boards. These are the objectives for your review, and they are included in your handout. We're going to start with some basic definitions. Patient safety is the absence of preventable harm to a patient during the process of healthcare. And quality improvement is systematic and continuous actions that lead to measurable improvements in healthcare. A medical error is defined as a failure to complete a planned action as intended or the use of a wrong plan to achieve an aim. The key or the point I want to highlight for the board will be that a medical error does not always lead to patient harm. In the next slides, we'll go through some examples of medical errors and the terminology to describe them. A sentinel event is an unexpected occurrence involving death or serious physical or psychological injury. And the key point that I want to highlight for sentinel events is that an investigation is mandated to determine the root cause of the event. So doing a root cause analysis, and that should be followed by an action plan. The purpose of this slide, I know it's a busy slide, it's just to highlight other examples of sentinel events as defined by the Joint Commission that they might expect you to know. So it will be something maybe to read once prior to the test. Some examples are unanticipated death of a full-term infant, discharge of an infant to the wrong family, an invasive procedure including surgery on the wrong patient or the wrong site, and severe neonatal hyperbilirubinemia. And next, we're going to have Amrit go through some other examples of medical errors and the terminology associated with it.
So as Arnaldo said, not all errors lead to harm, and that is a key point that we want to drive home. We have thousands of near-miss events pretty much every day in our hospitals or clinics where we're working. And for those thousands, we have hundreds of precursor events. A near-miss event, I like to think of like a stop sign that you might have blown through and nothing happened. So an error happened, you blew through the stop sign, nothing happened, everyone was fine. A precursor safety event, there are hundreds of those for every thousands of near-miss events. That is when it maybe reaches the patient, but no serious harm comes out of it. So you have a little fender bender at that stop sign, no one got hurt really, everyone goes about their business. And then for every 1,000 near miss or every 100 precursor events, we probably have one serious safety event that happens in our hospitals. And so that's, you blew through that stop sign and you had a serious accident where someone either died or got permanently harmed. So think of that as levels. And why this is important is in terms of reporting, the causes of all these events are really always similar. So blowing through the stop sign is probably what caused you to have a near miss or to have a fender bender or someone die. And knowing about those problems of what caused you to blow through that stop sign is what's going to help prevent the precursors and the serious safety events from reaching patients and causing real harm. So that's why it's important, and lots of quality and safety professionals focus on those near-miss events and reporting. So what is a serious safety event? Adverse things happen in hospitals all day, every day. We work in an environment where patients are very sick and sometimes people die. Not everyone that died or had a bad outcome is a serious safety event. A serious safety event is when there's a deviation from standard of care resulting in severe patient harm. So both of those have to be present for it to be called a serious safety event. Lots of examples happen every day in the inpatient and outpatient settings. So a medication event, a misdiagnosis, a delayed diagnosis, a hospital-acquired infection like a central line-associated bloodstream infection, treatment errors where we may have prescribed the wrong medication or misdiagnosed, delays in treatment, wrong site or site surgery, and then falls with serious injuries are some of the common things. And the Swiss cheese model is what we think of what leads to these serious safety events. So sometimes it's not just one thing that happened that usually leads to an adverse event or a serious death or permanent harm, it's usually 7 or 8 barriers that have been passed through for people to be harmed, for patients to be harmed in our hospital. So this is just an example to highlight that. So for example, there's an oncology patient, a patient with ALL that was admitted to a hospital. The hospital had a fever and neutropenia protocol that they automatically implement for every patient that comes in like that in that phase of treatment. In this scenario, the physicians delayed starting that because they were waiting for some blood tests. The nurses and residents questioned it, but didn't really escalate that to the level where anyone would make a difference from it. The lab had some delays and didn't call the results back in time. So here we've just shown 3 barriers, but typically what they say is there are about 7 or 8 barriers that can stop a patient from getting harmed, and it's when all those holes line up in that Swiss cheese that's typically when a real adverse event happens and it touches the patient and can cause significant harm. In terms of numbers, in the past, the big report that came out that led hospitals and organizations to focus on patient safety was the Institute of Medicine report in 1999. And at that time, they thought there were about 44 to 98,000 deaths in U.S. hospitals resulting from medical errors. Since then, there have been lots of studies, and the most recent was in 2013 in the Journal of Patient Safety, and this is what might come up on the boards, is the number now is at about 210 to 400,000 deaths that are caused every year from preventable harm or adverse events. And then the cost associated with that harm is 17 to 29 billion annually. As Arnaldo said, when sentinel events happen or serious events happen, the focus is on how can we fix it. And fixing it means you have to know what the problem is. So that is what is a root cause analysis, where you do a deep dive into what might have led to the event happening. And the focus is often on systems issues as opposed to personnel issues. So focusing on what were the systems problems that led to people making those mistakes. It should be, of course, a thorough and credible process, and then the outcome of a root cause analysis is coming up with a credible action plan, so things you can do to prevent recurrence of that event from happening in that setting or anywhere that it might happen in a similar setting. How do we make corrective actions to prevent these things from happening? There are lots of ways that hospitals are focusing on it. And the most basic way is process design. So policies and procedures you have in place to make you do the right thing. So things like hand washing or using foam, or bundles, so maintenance bundles for central lines. The next most reliable thing to do is reliability culture, so leadership driving so that people in the hospital are all speaking the same language, share the same culture, are accountable for your partners not making mistakes. And then finally, the goals are human factor integration, so making it dummy-proof or making it impossible to do the wrong thing and really easy to do the right thing. And these are things like, mechanical, so you can't plug a power cord of the computer into the USB port. Similarly, you shouldn't be able to put an IV syringe into an NG tube and hook up an IV med and give it through NG, or the other way around. When we think of reliability, if you look at the y-axis, so 1 in 10 means 9 times out of 10 you're reliably doing the right thing, and 1 out of 10 you're doing the wrong thing. And as you go up, you're getting more and more reliable, so 1 in 10 million, that one means once you're doing the wrong thing, and 999,000 times you're doing the right thing. So process designs just lead to about 1 in 100. Reliability culture takes it up to about 1 in 10,000, and human factors integration takes it up to 1 in 10 million. Industries that are really reliable are what we emulate in the healthcare industry is the airline industry, the nuclear power industry. Anyone want to take a wild guess where they are in terms of their reliability? How many times they're assured that they will do the right thing on this y-axis? Is it 1 in 10, 1 in 100 million? Anyone? All right, no one wants to guess. It's 1 in 10 million, so they get it right all the time nearly. If you're on a plane, that's the chance that you have of crashing is 1 in 10 million. The rest of the times, you're going to be okay. Where are baggage handlers in that? Anyone want to take a guess? They're in 1 in 100 or 1 in 1,000. Okay, so that's how many times your bag is going to get lost if you take a flight. And I'm sure most of us, if I ask for a show of hands in the room, we've lost our luggage at some point in our flights. Medicine, where are we at? So we're right there with the baggage handlers, 1 in 100 to 1 in 1,000. Overall, that as a group in medicine, some of the areas like the blood banks and anesthesia are a lot safer, so they're getting to the 1 in a million to 1 in a 10 million, but we strive to be in 1 in 100 million. That's how reliable we need to be. So, like I said, these are just examples of the industries that are highly reliable, and we learn a lot from that. And what they've paid attention to is a lot of these 5 high reliability principles. And just to go over them briefly, there is sensitivity to operations. So they are focused on what their operations are. Their top leaders know exactly what's going on in their organizations. They have a preoccupation with failure. Failure is not a bad thing when you're highly reliable. When you know where your failings are, that's how you can know how to avoid those and succeed. Deference to expertise, so stopping and asking an expert and not just winging it is one of the keys to high reliability. Resilience, bad things do happen, but just bouncing back from that. And then reluctance to simplify, so not just taking for granted, but really focusing on detail and attention. What's been shown over and over again in these high reliability industries is that all of these lead to a state of mindfulness and high reliability, and then you can deliver exceptionally safe and consistently high quality care. Another thing that the safety industry has come a long way in, and in hospital and patient safety, is medical error disclosure. In the past, when medical harm happened, often patients didn't even know. They would think it's just a bad outcome. If they did know, there was a lawsuit. We've come a long way since those days, and a lot of highly reliable organizations choose to disclose when a medical error happens. So, and they have their ways and policies in place within their organizations. Depending on state law, they may be different, but medical error disclosure is encouraged in pretty much every state in the US now. Families want it. There is lesser litigation because of disclosure, so even when really bad things have happened and hospitals have said, we're sorry, we made a mistake, we're going to try everything we can to fix it and to not be able to cause it in the future. Families have mostly partnered with those hospitals to move forward, and litigation has decreased because of that. Of course, keep in mind, litigation is not the be-all and end-all. It is patient care that we're trying to improve. And then finally, the second victim is another term that we have come to learn. And who is the second victim is the caregiver. Initially, the focus is always on, of course, the patient that was harmed and their family. So they're the first victims. But what we've seen in patient safety and quality circles is everyone that's providing care for those patients that get harmed also have a huge impact. And helping them to cope is key in everyone moving forward. So the term second victim might come up on the board. So just keep in mind that's the caregivers, the medical providers that are taking care of the patient. And I'll turn it back to Arnaldo.
Yep, so we'll now briefly move to quality improvement. And there are 2 points I want to highlight. First, the model of improvement, and that will be followed by data analysis in quality improvement. In terms of the model for improvement, it's a systematic framework used in healthcare to conduct quality improvement projects. And the components are pretty much 3 basic questions followed by PDSA cycles. The first step is to set an aim. And in order to achieve that, you would ask yourself, what are we trying to accomplish? The second step will be to establish your measures. And in order to accomplish that, you will ask yourself, how will we know a change is an improvement? And the third step, it's going to be identify your changes or interventions. And in order to achieve that, you'll ask yourself, what changes can we make that will result in an improvement? Once you go through those 3 basic steps, that will be followed by your PDSA cycles, which stands for Plan, Do, Study, Act, which will allow you to quickly test changes on a small scale. And as you can see, it is a cycle. So once you test a change, you'll be able to make observations, collect data, look at your data, and then decide if other changes need to be done, and then go again through the cycle until you are achieving or getting closer to your goal. And the second point regarding quality improvement that is important for you to know for the boards is that data should be analyzed over time. So the idea is that you start with baseline data, and once you start testing your changes or your interventions, then you look at the data. Are you moving towards your goal? And once you look at data over time, meaning weekly or monthly or every year, you'll be able to keep going back to PDSA cycles to make sure you are achieving your goals. All right, so we're gonna move to some board questions. So the first one is, you're seeing the last patient in your clinic and realize that you are 15 minutes late for an important meeting. You need to give the patient 2 prescriptions and referral information for a subspecialty clinic. Of the following, the intervention most likely to prevent a medical error in the scenario described is, then you have your options: increasing nurse-to-patient ratio, increasing time allotted for each patient encounter, providing a patient handout about subspecialty referrals, reducing physician fatigue, or using computerized physician order entry. All right, so 60% got the right answer, which is number 5, using the computerized physician order entry, which is one of the proven interventions that in this scenario, which is pretty much a rush kind of scenario, will be able to prevent making an error. The next question, you are on a committee charged with decreasing the infection rate in your hospital system. The committee has identified hospital-acquired MRSA infection rates in intensive care units as a focus for improvement. A recently published article demonstrated that cleansing each patient with antibacterial soap daily decreased the incidence of MRSA infections in an ICU. Your hospital system does not currently use this practice. The committee plans to evaluate the study of this practice using the model of improvement, in other words, a PDSA cycle. Of the following, the most appropriate first step will be to develop a procedure for ICU staff to use antibacterial soap to cleanse patients, implement a policy to cleanse ICU patients with antibacterial soap daily throughout the hospital, implement a policy to cleanse patients daily in a single ICU, review MRSA infection rates in an ICU that already incorporated the intervention, or wait for more evidence that using antibacterial soap decreases MRSA infection rates. Okay, so yep, that is correct. Number 1, developing a procedure. So that's the P, that's your plan. As you can see, 2 and 3, it's implement, and that's at the end of your quality improvement project. Once you do multiple PDSA cycles, then you move to implementation. Next question, a mother comes into your pediatric office to verify her child's antihypertensive medication. Her son was recently discharged from the hospital, and a new prescription for clonidine was called into the local pharmacy. After she got home, after picking up the prescription, she thought the pills looked different than the clonidine pills that he was taking previously. She did not give the new pills to her son. She shows you the bottle that is labeled as Clonopin. Of the following, this scenario is best identified as an adverse drug event, near miss event, never event, Sentinel event, or a serious reportable event. So correct, this is a near-miss event. It did not reach the patient. It did not cause harm, but it has the potential of becoming an adverse drug event. So that's why it's not number one. And we went briefly through the list of Sentinel events, and this was not one of those included in the list. All right, and the last question, which of the following is not an example of a Sentinel event subject to review by the Joint Commission? Rape, patient suicide, discharge of an infant to the wrong family, or discharge of an elderly patient to the wrong assisted living facility? So actually, rape is a Sentinel event, and it was included in the list that I provided. So just make sure to go through that list prior to the test. The correct answer will be number 4, discharge of an elderly patient to the wrong assisted living facility. The other options, patient suicide and discharge of an infant to the wrong family, are also Sentinel events. All right, and that is all. Thank you so much.